Welcome to Parasitic Diseases. Today's topic is Strongyloidiasis, an infection and a disease also caused by Strongyloides stercoralis. Strongyloides has a global distribution. It's reminiscent of the distribution for hookworm, but it's not as prevalent in most areas of the world. Even though, in this case, Strongyloides has reservoir hosts. It can infect dogs, it can infect non-human primates. And in that sense, Strongyloides has a wider distribution in terms of host species, but a narrower distribution in terms of infection in human populations. It was originally discovered in Cochin, which is a place that is of a disputable geography. Some people think Cochin refers to the Indian Cochin. Others think that there was a place in China that was originally named Cochin and then the name was later changed. So we have a difficult time in actually discovering the origin of the word Cochin China diarrhea, because back in the day, Beauvais was stationed in either Cochin, China or Cochin, India. I guess we should know the difference between those two places by now, but suffice it to say that he coined the phrase Cochin China diarrhea to refer to a very special diarrhea which was not associated with any of the other parasite entities known at that point. It was for Ashkenazi to actually show the pathology of this infection, and most of that was done on autopsy. So now you know that this could be a fatal infection as well. A second species, Strongyloides fulleborni, is fulleborni, discovered by Dr. Fulleborn, has a similar life cycle to Strongyloides stercoralis. So we're going to use Strongyloides stercoralis as our sentinel organism for the genus Strongyloides. This is a weird parasite. This parasite can't seem to make up its evolutionary mind as to whether it's a free-living nematode living in soil or a parasitic nematode living in the gut tract of mammals. Shown here is the free-living adult female. This worm, as a free-living adult female, is reminiscent of Caenorhabditis elegans. So obviously, when you trace these origins back through their evolutionary history, it's possible that through random mutation, this worm acquired the ability to infect maybe mammals, maybe dinosaurs. I don't know how old a genus this is. I don't think anybody else does either. But nonetheless, at some point in its life cycle, it developed the ability to extend its host range from the soil, which isn't typically considered a host, to all the animals, the mammals at least, that were walking on the forest floor at that time. There are males associated with this infection as well. I don't depict the male here because after mating, the male indeed dies and disintegrates. So it's short-lived. The parasitic female, on the other hand, is totally morphologically different, as you can see. The eggs are shown here, sequentially being produced in the ovary, and they're shed one at a time in the niche that this worm occupies, which is a unique place in the body indeed. So let's talk about the life cycle. And it's complicated, of course. It's always going to be complicated from this point on because we've already discussed Anaerobius, direct life cycle, Trichuris, direct life cycle, Ascaris, looks like it's going to start off as a direct life cycle, but it's got this nuance of migrating through the tissues. Hookworm as well is invading the skin, and it has this Ascaris type of life cycle, and Strongyloides fits into that pattern as well. It has a cycle that's reminiscent of the Ascaris and hookworm life cycle. This worm also has the ability to penetrate unbroken skin, and as the result, the larva finds its way into a capillary, circulates throughout the body, migrates up the bronchia into the trachea, across the epiglottis, is swallowed, and develops into a parasitic worm. And notice I'm not saying whether it's male or female. It develops into a parasitic worm. This infection is unique among nematode infections, or I should say semi-unique, because there's one other infection that actually does this as well, only one other. So there are only 2 worms that actually, with a single larva to infect, can result in a full-blown infection in which more adult worms are actually produced throughout the course of the infection. The same is not true for any of those nematodes that we've discussed so far. So those worms, you eat an egg and you get an adult one. In this case, you get penetrated via the skin and you get one adult that can give rise to larvae, as shown here. And this worm is both male and female. So it develops first to a male, stores the sperm, reconstructs itself as a female, fertilizes the eggs, and the larvae are then produced and pass out of the body as second stage larvae. Now remember, the third stage of these worms are the infectious stage. So a person with a normal immune system that's able to interact with this parasite to prevent it from producing eggs that develop within the same host to a third stage will be shedding larvae of the second stage. And this is a very important distinction because there are situations where immunity is reduced, organ transplantations, HIV, AIDS, other chemotherapeutic approaches to cancers, which allows the immune system to release its grip on the developmental cycle of this parasite. And as a result, the larvae are able to develop to the third stage within the same host. And when that occurs, they penetrate the wall of the large intestine in this case, enter the blood supply, return to the trachea, up through the epiglottis, are swallowed, and they can resume the infection as another adult parasite. So this is a nuance of this infection, which is called autoinfection. The consequence of this infection, recycling again and again in the same patient, results in a very heavy infection. And as we'll see, it's not simply explainable. The disease that it creates is not explainable simply by the number of worms present. Because what is the disease that this causes? Well, we know it as Cochin China diarrhea, but there's another aspect to this that we must consider when we discuss the pathology. And we'll see about that in a moment. Shown here are 2 of the reservoir hosts that are common throughout endemic centers, and surprisingly, or perhaps not so surprisingly, when primates are imported to animal colonies for use in medical experiments, they must first be checked for the presence or absence of Strongyloides, because a number of infections have been acquired by veterinarians working in non-endemic centers. So the only way to explain that is to realize that they have encountered the feces of newly imported primates, and this was discovered during the 1960s and 70s, so that it became routine when primates were imported into animal colonies. They were first treated for Strongyloides before they were allowed to interact with the scientists. Dogs are more problematic because they're free-roaming in most cases and can acquire this infection. A survey done in the 1970s, as I recall, but it could have been in the 80s, doesn't matter really, showed that in Montreal, of all places, that 3% of the dogs harbored Strongyloides adults because they were shedding third-stage Strongyloides larvae. And that's a very cold climate where transmission is only limited to the warm summer months. The parasite, once it's deposited in the soil as a second-stage larva, just to complete the picture for the normal immunocompetent patient, starts to develop as a third-stage worm, and then a fourth stage, and then an adult. And now it could produce either male or female worms depending on the sex of the larva. They then mate, eggs are produced, the eggs hatch in soil, the larvae feed on bacteria, and they continue to carry out this life cycle until they have exhausted their resource of food. At that point, instead of third stage larvae going to fourth stage, the second stage stays as a third stage larva, accumulates as large numbers of worms on the highest object in their environment, just like the hookworm larva, and they begin questing for people. Another interesting aspect to the third stage larva of Strongyloides is that it can swim. So this worm can be waterborne as well as simply contaminating an environment, and you encounter it by touching them. You can actually drink water in which these larvae are present, and they can penetrate the buccal cavity and enter the bloodstream that way as well. So this worm has a lot of different survival strategies built into its genome, which make it quite a unique infection to discuss. This is a biopsy taken from a patient that was originally suspected of having Crohn's disease because part of the syndrome of Strongyloidiasis is a malabsorption syndrome. The diarrhea is so intense that it causes flattening of the villi. And at that point, the patient begins to absorb in another way the food supplies that they encounter. The same was true, by the way. Flattened villi were also noted with Giardia infection, one of the first parasites we discussed. So flattened villi can be elicited by a variety of mechanisms. And in this case, this is an infection in which the adult worms live embedded within columnar cells within the small intestine. And you can see none of the worms that are adult are found in the lumen, sort of hanging into the lumen, as you would see with Trichuris or Ascaris or Anaerobius or hookworm. Indeed, this worm remains in its intramulticellular niche, and it produces the eggs there. The eggs are then develop in that niche, and when they develop to the second stage, they penetrate out into the lumen and are extruded with the feces. Here's a skin sample, probably taken from an experimental animal, and in the skin you can see the larva, but in a very heavy case of human infection, you could expect to see these worms all over the body, including skin and virtually every other organ as well. So cell death in the small intestine is created by the worms invading the epithelial cells and is perhaps the explanation for the diarrheal disease that results from the buildup of adult worms until the immune system actually kicks them out with Th2 type responses. Now Dr. Daniel Griffin is going to give a clinical vignette illustrating further the pathogenesis of this infection.
A 29-year-old Peace Corps volunteer working in Rwanda presents with 3 weeks of feeling poorly. She reports that this started with a macular papular rash on the lower back and down onto the upper leg, sort of sparing the seat area. She developed fatigue, cough, and then had diarrhea. Patient was noted to have 51% eosinophilia with an absolute eosinophil count of 9,000. Patient had no significant exposure to fresh water. The stool is sent for ovum parasites, and larvae are seen in the stool. The individual remembers an episode where they sat down in what they then realized was feces. The feces was all over the same area as the rash. They were unable to tell what kind of feces, whether it was human or something else. But this is an area with a significant number of people and a significant number of non-human primates. Now, clinical disease for Strongyloides. Following infection in immunocompetent individuals, there may be no symptoms, or maybe just a watery diarrhea, but the degree really varies with the intensity of infection. In approximately about a quarter of the people that are symptomatic, you can have states alternating diarrhea with constipation, some abdominal discomfort, vomiting, epigastric pain, and some of this can worsen when one eats. The majority of infected patients display no symptoms following infection, and peripheral eosinophilia may be the only evidence of acute infection. Some individuals may report skin reactions, commonly called ground itch, due to penetration of the skin by the infecting L3 larvae. The rash of ground itch is characteristically on the feet, but will be located wherever the larvae penetrate. Now, children with Strongyloides stercoralis may develop a syndrome characterized by anorexia, cachexia, chronic diarrhea, fat, protein malabsorption, abdominal distension. This can lead to impaired growth. But again, this can be reversible with specific anti-helminthic chemotherapy. Disseminated strongyloidiasis can present with migration of larvae through the skin, giving rise to a serpiginous, creeping, urticarial eruption known as larva currens. Now, the larvae, these sort of running larvae, they can move as fast as 5 to 15 centimeters per hour, leaving intense red pruritic streaks on the abdomen or lateral thighs. Now, that's not the only rash with Strongyloides. I want to point out with disseminated Strongyloides, you can also get a presentation where there's a petechial purpuric rash, this periumbilical parasitic thumbprint purpura. And this is, when present, can be present on the abdomen and lateral thighs. All right, what about diagnosis? Now, microscopic identification of the characteristic larvae in the feces. And this is something that's a little bit different. We're used to seeing eggs, but here we're actually seeing larvae in the feces when we see it. The sensitivity of a single stool is not great. It's less than 50%, maybe as low as 30%. And this is because, in contrast to some of the other parasites where we have thousands, hundreds of thousands of eggs, let's say, here, maybe about 50 L2 larvae are released per day by each adult Strongyloides, so not a high amount. So how do we deal with this lack of sensitivity? One is we can do fecal culture. And so laboratories that are skilled, experienced, comfortable with handling the organism can do these techniques where they take a fetal pat, they take some of the feces, they put it on an agar plate, and then they're going to detect the tracks of bacteria that are dragged along as larvae migrate out of the stool. Some laboratories will actually amplify the number of larvae by mixing the stool with a bone charcoal, and as Dr. Despommier described, they're taking advantage of their heterogenic life cycle. So the fact that these larvae can replicate in a soil-like preparation, they're creating that. So this is a co-pro-culture technique. You can also do serological testing. This is where we're looking for IgG, which is responding, so our evidence that our immune system has seen Strongyloides. But again, sensitivities here are about 85%. We can get some cross-reactivity, so this needs to be considered. Nucleic acid amplification tests. These are under development. They're available in some places. We're looking at multiplex quantitative PCRs. And these, I think, are going to be really helpful in increasing our sensitivity, as well as helping in the context where we might have parasite co-infections. And here is an L2 rhabdidiform larvae seen in stool. Now the tail of the L3, that's the infected filiform larvae. The L2 is normally what's shed. The L3 is normally what's infected. You can see here that it has a characteristic form which allows it to be distinguished. This forked tail, which allows it to be distinguished from the hookworm larvae. Treatment. Now, two ways. I'm going to break this down. Uncomplicated infection. This can be ivermectin, given just once, then repeated 2 weeks later. Albendazole is another option, but it is not as efficacious. It's an inferior option. Now, disseminated disease. In disseminated disease, ivermectin is the treatment of choice. This is usually given weight-based, 200 micrograms per kilogram per day. So this is going to be determined by the clinical response. Now, some people will add albendazole to this as well if they're concerned based upon seriousness of infection or poor clinical response. In some critically ill patients, they have been treated off-label with subcutaneous preparations of veterinary ivermectin and actually done quite well. This is off-label, not FDA indicated. Now, the drug of choice, as we point out, is ivermectin, and Bill Campbell and colleagues working at Merck developed ivermectin, and in 2015, he was awarded the Nobel Prize in Medicine. Now, what about our patient? The stool larvae was diagnosed as Strongyloides stercoralis. Patient was initially started on albendazole because that was the drug that was available, but there was persistent larvae in the stools. She was then switched to ivermectin and did well clearing the larvae from the stools.
Preventing and controlling strongyloidiasis is as easy at some level as it is for hookworm and ascaris and trichuris. Basic sanitation, of course, is the approach. However, the caveat here is that there are other reservoir hosts to contend with in some areas of the world where dogs and non-human primates occupy the same habitat as people, peridomestic habitat. And so that complicates the issue of control. And in fact, that's the reason why it hasn't been controlled in those areas. To learn more about what a hyperinfection syndrome looks like, here's a good case to serve as the poster child, so to speak, for what hyperinfection can cause in a particular patient, and a good review of the literature as well. We've discussed Strongyloides at least twice on TWIP. You can access TWIP at microbe.tv/TWIP and enjoy other aspects of this discussion as well. Next time, we'll discuss trichonellosis or Trichinella spiralis. Thanks for listening.